I guess we can start now.
Okay, welcome everybody to this quarter's meningioma patient support group. This is a quarterly webinar that we host just to provide information for patients that have been diagnosed with meningiomas. The purpose of the presentation tonight is going to be primarily to foster discussion among several physicians regarding management of meningiomas, and then we'll save some time at the end of the webinar to answer any questions that participants may have about any of the meningioma cases presented or about any of their own meningioma cases. So if you have questions, you can submit them as we go along to the question and answer box on the bar, and we'll answer them when we're done with our presentation in the order in which the questions have been submitted. Okay, so tonight I'm going to present a series of 5 meningioma cases to our panel, and the panel's not seen these cases before. So it'll be new to them, and we can see how they will decide to manage the cases. I'll ask them some questions about each case and provide some detail as we go along. So David and Neelan, you guys ready?
Yep, we're ready.
Okay. So here's the first case. We'll start with a relatively easy case for you guys. This is a 49-year-old male, was traveling in Asia, and over in Asia, they have these MRI facilities where you can get a kind of a full body MRI scan just to get checked out. So this 49-year-old male decided to get a full body MRI scan, and everything checked out okay, but they were told they had something popped up on the scan in their head. They have no neurologic symptoms, and their neurologic exam is completely normal when you see them in clinic. Okay, so here's the scans, so David, I want you to kind of maybe just start by describing what you see on these scans.
So there's a homogeneously enhancing dural-based mass below the tentorium.
Mm-hmm. So this structure right here.
Yeah, in the midline, and it's going to be like torcular area, giving some pressure to the cerebellum. But seems like there's no peritumoral, like perilesional edema surrounding the mass.
Okay, so David's identified this rounded structure. This is called an axial view, it's a horizontal view. This is a coronal view, which is a vertical view. And this is a sagittal view, or what's called a profile view. So the nose of the patient's here, here's the forehead, and here's the back of the head. So what is this structure here, David? This structure
called superior sagittal sinus, which is a venous drain of the brain. So it's going to be like mainstream of the vein draining out from the brain. Yep.
Okay, and then so here's the same vein shown in the cross section here. So Neelan, patients not having any symptoms at this point, what they're sitting in your clinic kind of asking for different treatment options. So what would all the treatment options be for this patient? And then maybe give us the pros and cons of each one.
So the treatment option, the first treatment option would be open surgery to resect this lesion. Then the pros of that are you resect the lesion, you get a tissue diagnosis so that you can what the pathology of it is. It a grade 1 meningioma, a grade 2 meningioma, and you can get a gross total resection. You don't have to worry about the lesion again, and depending on the grade, obviously. The other option would be cyberknife radiosurgery. And that's again, the pros of that is not as invasive. You don't have to do a craniotomy. There's no skin incision involved. The patient can do it on an outpatient basis. The thing is that it doesn't get rid, the tumor doesn't shrink, but it will kill the tumor cells and stop the growth. There's another option doing a combination of both, doing a partial resection. There might be invasion of the sinus of the straight sinus there, of the straight sinus there, and so there might be some they may need to do some, may not be able to take out all the tumors. So cyberknife radiosurgery in combination with open resection. And the other option is just observing it for now, since the patient is not symptomatic. Could observe it, get another MRI in 3 to 6 months to kind of see the growth, if it grows, and you can get some idea of the grade of the meningioma by just observing the growth pattern.
Okay, David, Neelan talked about grade 1 and grade 2. So can you tell us briefly what does that mean?
So
There's a grade.
Yeah, there's a grading system based on WHO classification. It's based on like pathologic images, and so like basically it's, the main key point is they count the cells, which is like, under whether it's dividing. So basically for grade 1, that means completely benign, and grade 2 is called atypical tumors. And I mean, grade 1 is majority, like more than 90%, and grade 2 is about like 5 to 9%, and grade 3, there's like basically 3 grades for meningioma, and grade 3 is called anaplastic. And although it's benign, but it's the nature of that tumor itself is more like malignant. It grows everywhere, and it comes like as a multiple lesions from the beginning mostly. So there are 3 different types of grading system, and based on those grading, the treatment plan can also differ based on that. So example, like for grade 1, after resection, if there's no further growth, it's safe to watch. For grade 2, it's maybe better to treat with radiation if needed. For grade 3, we have like diverse other therapies, but there's no like complete published cure for that at this point. Yeah.
Okay, so Neelan, how long do you think this meningioma has been here?
So these are, if this is grade 1, we don't know the grade, but these are generally slow growing lesions. So I'd probably say 5 to 10 years.
Okay. So if the patient chose to just observe this, like you said, and when would you want to get the next scan?
I would probably say in about 3 to 6 months, probably closer to the initial scan in 3 months, just to see if there's any growth, and then we could kind of increase the interval after that, depending on what we see on the follow-up scan.
Okay, are meningiomas inherited? Meaning, does this person have to worry about their kids having meningiomas?
No, they're not inherited in this case. No. So you shouldn't have to worry about his kids or his family.
Okay. David, so you have the patient basically says, okay, what specifically do you recommend? Neelan gave, 4 different actually possibilities, but in this case, 49-year-old male, no symptoms, never would have even known they had this meningioma except for their full body scan. So what's your kind of final recommendation for this patient?
At this point, I think like all options are like quite feasible, but and also like recommending just follow up, doing nothing and just observing it's not a crazy idea, but I think the size of tumor itself is quite large. So just waiting may cause some symptom, very soon, and also can cause some swelling nearby. So I think at this point it's still very safe to offer stereotactic radiosurgery. And if we consider surgery, the risk of like getting the complete tumor resection, like basically may have some invasion to that sinus, so it may not be easy. So I would say, like, even though we do surgery, we may have something left over there. So followed by, I mean, we may need to follow with radiosurgery for the residual tumor. So I think eventually, like, my recommendation will be radiosurgery. Yeah.
So treat it now before it gets bigger and causes symptoms.
Yeah. I think.
Okay.
Yeah.
Neelan, any comments? Any thoughts on how you would manage this?
I think that radiosurgery is a good option. I think I might actually, because the patient is asymptomatic at the moment, I don't think it would hurt to wait to get an interval scan in 3 months just to see if there is any growth. And then at that time, we can kind of revisit the option of radiosurgery. I don't think in a 3-month interval, it will grow to cause symptomatology. But I think also offering upfront CyberKnife radiosurgery or stereotactic radiosurgery would be also a good option as well.
Okay. Okay, let's move on to the next case. So this is the second patient, 58-year-old male. So he comes in, says that for the last 4 years, he's been reporting some periodic double vision. And he thinks it's his right eye that's the one that's the problem eye. But when you look at him in clinic and do all your neurologic testing on him, the exam is completely normal. Okay. So, Neelan, why don't you describe what you see on these two scans?
So on the left, it's an axial cut MRI. It looks like there's a contrast enhancing lesion. Yep, exactly. In the area of Meckel's cave in the cavernous sinus, kind of abutting the right temporal lobe, and extending back into Meckel's cave. Yeah, and also along, and looks like there's some enhancement too of the tentorium as well. And this is probably, I think, classic and pathognomonic for a cavernous sinus meningioma.
Okay, what about in this picture here?
Here, also, this is a coronal cut. Again, you're seeing this kind of space-occupying skull-base lesion. You've got an enhancing component there. It looks like it might be abutting the optic nerve, which could be explaining his symptoms.
Okay, what's this little black circle here?
So that black circle is likely the carotid artery running through there.
What's this black structure here?
That's like the cavernous sinus.
Yeah. Okay. So why is this carotid artery on the right side smaller than the carotid artery on the left side?
Oh, it's because it's being compressed by the tumor.
Okay. So if I told you that this patient had a 6th nerve palsy, which is causing the double vision, would that be explainable by this tumor?
I think so. I think it would be, yeah, because it is extending back, and I think that, yeah, that's definitely explainable by this tumor.
Okay. So David, what's your thoughts here? 58-year-old guy, the 4 years of kind of this double vision, but exam seems to be normal. And this is the first MRI scan he has, so we don't have anything prior. How long do you think this has been there?
I think at least more than 4. You said the symptoms has been like 4 months.
4 years. Four years of symptoms.
So it's going to be definitely more than 4 years. So maybe like also like 5 to 10 years, I would say, like, yeah, 5 to maybe 8 years.
Okay. What are the options for this? This is obviously what's called a skull-base meningioma. So it's entwined with the blood vessels. As Neelan said, the carotid artery runs through the center of the tumor. So, you could injure that, and that would obstruct blood flow to the brain. So what is this something you can just resect surgically?
I think like complete resection is going to be very, very difficult, and I wouldn't recommend to do that at this point, because we have like advantage of stereotactic radiosurgery at this point. So, but first of all, like I think observation is not a good option at this point. He's already symptomatic. I mean, although like neurologically he was normal, but the symptom, his double vision and his visual symptom it seems likely to be related to this tumor. And I think, there's no point to wait for, wait and just scan and just observe. So in my point of view, I would recommend at least stereotactic radiosurgery, or other option could be like partial resection. But this tumor itself, like even to do partial resection would be quite invasive surgery, and it's going to be like complex surgery. So my recommendation will be radiosurgery at this point. Yeah.
Okay, so Neelan, David says the patient's young and this is already pretty sizable, so observations not, he doesn't recommend that, and he says surgery would be a challenge given the location. What are your thoughts on this?
Yeah, it definitely would be a challenging case to do this with open surgery, but I think, I mean, it depends on the surgeon comfort. I think because there is some symptomatology there. And you know, the SRS isn't necessarily gonna to shrink this tumor and the mass effect that's causing the symptomatology. I think it would be okay to kind of visit a combined approach using you know, using a skull-based approach to safely and partially resect the tumor. And then to consider, and not to fully resect the tumor, because as you said, there's the carotid arteries entwined there. This is the critical structures. I think that doing a partial resection of the open resection followed by cyberknife radiosurgery would be a good option.
Okay, case number 3, 66-year-old female. So she comes to clinic saying she's got a 2-year history of worsening numbness. This says left leg, but it's actually kind of both legs below the knee. The numbness is getting progressively worse than the feet, but left side's maybe a little bit worse than the right. She reports subjective weakness, which basically means that she feels she's weak, but it's not clear that you can kind of pick it up on testing. Her neurologic exam is normal, so that's why the weakness is subjective. When you test her, she's got full strength, but even though she feels weak, but she does have decreased sensation in both legs below the knee, left greater than right. So before we go to the films, Neelan, what do you think of this lower extremity weakness? What's the most likely cause of that? Not the weakness, the bilateral foot numbness.
The bilateral foot numbness.
Mm-hmm.
Probably, I'm thinking there's probably some
broadly, like general realm of all neurology. What's the most common?
for the numbness.
Yeah. What causes the numbness, like in extremities and patients as they get older?
Oh, well, I mean, it could be just due to, like, I mean, if I'm not sure what her medical history is, it could be just due to
She's
neuropathy,
diabetic.
diabetic neuropathy then, yeah.
Okay. So this is a situation where the patient has diabetes. Diabetes can cause what's called a peripheral neuropathy, which is injury to the small nerves of the hands and feet, and it causes kind of this numbness sensation. So already it sounds like, you know, she's having symptoms, but the symptoms may or may not be related to what we're going to see on her exam. So David, why don't you comment on what you see on, these are a couple of slices, horizontal slices through the brain. So tell me what you see on the slices.
We're seeing the axial images of the brain and, you know, T1 contrast image, and we can see like mostly homogeneously enhancing, but like there are some, like, you know, in the core there are like some, you know, suspicious like necrotic tissue or some like heterogeneously enhancing portion in the middle. So a bit more irregular surface and like space occupying large dural-based mass on right sphenoid wing, giving some, maybe this could be just related to the angle of the cut, but maybe giving some pressure to the right eye, the orbit as well.
Okay.
Yeah.
What is this black stuff here, this curve?
Is that ICA, or I don't know, like
So it's part of the orbital apex, the bones of the orbit. So what do meningiomas, what can they do to bone, adjacent bone?
They can erode it. I mean, have like bony erosions. So is that like just
So sometimes meningiomas can erode the bone. What can they do in the opposite direction to bone? Can they thicken bone?
Oh, so is that so
Hyperostosis.
Yeah, hyperostosis.
Yeah.
Yeah.
So that's what this is. So when a meningioma grows off the bones of the skull, it can thicken the bone and cause actually bumps in the bone to development. So this is some hyperostosis there. Okay, so Neelan, what's this darker gray stuff? I mean, the brain is this gray here, but what's this darker gray stuff?
That's likely edema caused by
What's edema?
edema is you can get different types of edema. It's basically an extravasation of fluid flowing into the brain from another compartment. With tumors, it's likely caused by disruption of the blood-brain barrier. So fluid from the blood vessels flows into the brain, basically, and causing this kind of causing this fluid in the brain and increasing the mass effect or the pressure from the tumor.
Okay, so the brain has a left and right half here, but it doesn't look very symmetric here in the middle. What's going on there? Like why isn't the left half and the right half looking the same?
So the tumor is basically pushing this is the mass effect or the pressure from the tumor is kind of pushing the brain over a little bit. So you've got kind of displacement of structures and a violation of the normal anatomy.
Okay. Here's some other views. Couple of obviously this is the tumor here on a coronal view or horizontal view. David, what's this black structure here, this pipe?
That's carotid artery.
Okay, where does it supply the blood to?
To the whole brain. This
Whole
is
brain.
right
So
side.
the tumor is right up against the carotid artery, right?
Exactly,
What's this little gray band here?
That's optic nerve.
What does optic nerve do?
So basically, it's the nerve for the vision. It goes to both eyes. Yeah.
Okay,
And
so
exactly
this tumor is close to both the carotid artery and the optic nerve.
Yeah, and that is like basically like optic chiasm, like crossing. Yeah.
Okay, and then this is a sagittal view, shows the tumor kind of location kind of behind the patient's right eye.
Yeah.
So Neelan, what do you recommend for this patient? First of all, do you think this is causing the leg numbness?
No, it's not causing the leg numbness. That's likely due to the diabetic neuropathy. So, and she's subjectively weak. We don't know what's causing the subjective weakness, but objectively, she has no findings except for that numbness. So, but this is a lesion that it's big and it's putting pressure on the carotid, and it's getting close to the optic nerve, if not pushing pressure on it. And so if it's not symptomatic now, she will have symptoms. I would try for a open surgery to resect this tumor as much as safely possible, and then anything that's left over, I would try for stereotactic radiosurgery.
Okay, what area of the tumor are you worried about not being able to get it all out? Like where would, if you said you could get most of the tumor out easily, but where would the difficult part of the tumor be to get out?
Mainly around the carotid artery, I think, because of obviously you want to avoid that and avoid manipulation of the carotid artery.
Okay, David, how long has this tumor been there, do you think?
Wow, and based on the size, I think it has been like about 10 years, probably.
Okay,
or more. Yeah.
And she's 66-year-old female. Are meningiomas, do they occur equally in males and females?
No, they have like more higher prevalence in women. So it could be related to some hormone, but basically like more in females.
Okay.
Yeah.
So what do you recommend at this point for this patient?
I agree with Neelan that surgical approaches seems necessary at this point. Regarding tumor debulking, at least like we should reduce the mass effect there. And after that, I think we can, based on the pathology and how much there, we have like residual there. So then we can consider radiosurgery for the remnant, or if necessary. Yeah.
Okay, both of you guys at so far have used the term debulking a couple of times. What does that mean to a layperson?
So
what does debulking mean?
reducing the volume of the tumor. So like eternally, like taking out the pieces of the tumor, I will say, yeah.
Okay. To get there, okay, so as both David and Neelan have identified here, this is a large tumor. It's putting pressure on the brain, and we see that pressure manifesting as both fluid or edema in the brain, so swollen tissue, as well as what we call midline shift, where part of the right side of the brain is being pushed over to the left side. And both of these point out to the kind of significant size of the tumor. This is a couple more views on here. So in this view here, the edema or the swelling in the brain is more pronounced. It's called a T2 view here, where we can see the swelling more clearly than just being a little bit different shade of gray. It's bright here. So on this scan to the right side, Neelan, what is this structure here, this long structure?
That's the right optic nerve.
Okay, so what's the relationship to the tumor to the optic nerve? Is it close, far, abutting it? What?
It's at this point it's abutting the optic nerve. I can't tell if it's putting any. I don't think it seems to be putting any pressure on it at the moment, but it's abutting the optic nerve.
Okay, David, what are the risks of this surgery that you're proposing?
So basically, like, because it's right, like it's just butting the optic nerve, so you may have some injury to the optic nerve, like not. So although you may not have like physically, like you don't really cut the nerve, but also like having some bleeding in the nerve itself may cause like ischemic damage. So there's high risk of optic nerve damage, definitely.
So what are all the risks? Maybe just kind of run through the risks in general of this type of surgery.
So like having, like, related to all type of surgery, like invasive procedure may include bleeding risk, infection risk, and risk related to anesthesia, of course. And especially for this type of tumor in this location, we'll have a chance of optic nerve damage, ICA, like carotid damage, which can cause like severe stroke, and also lead to death in worst case scenario. Yeah.
So Neelan, okay, so David's kind of identified some risks that sound significant, like injury to the carotid artery, the blood vessel, and injury to the vision nerves. What percentage wise, where would you peg those roughly? I mean, how likely are they to happen?
For injury to the optic nerve, and the carotid, I would probably put them between somewhere. Again, it's surgeon dependent, somewhere between 4 to 8%.
Okay, so not zero, but not 50%.
Not high,
right,
not
okay.
high. Yeah.
Okay, okay. So next case for you guys is number 4 out of 5. 76-year-old woman. She's got some memory issues. Got a normal neurologic exam. So she got a brain MRI scan because her primary care physician was worried about these memory issues and said, let's just do a quick scan and check to make sure everything's okay. And then got called and said, hey, the good news is your brain looks great. We don't see anything wrong with the brain. But right at the edge of the scan, at the bottom of the scan, right where the neck starts, we saw something there, and we needed to discuss. So this is the brain MRI scan. And they saw something down here at the bottom of the scan. So David, what do you see on this scan?
So in C1 and C2 level, you can see behind that. So intradurally, you can see dural-based mass, contrast enhancing, homogeneously enhancing mass, giving pressure to the spinal cord, like really occupying majority of the spinal canal. Yeah, but
so
seems
here's
like
so here's the spinal cord here, and David correctly said this kind of round structures and pushing on the spinal cord. Okay, so this was a brain MRI scan, not a cervical spine MRI scan. So the patient got brought back, and now we're going to get scans of the cervical spine. So what do you see here?
So basically same tumor, like contrast enhancing dural-based mass, more dominant on the left side, based on the axial image on the right. So anteriorly is located anteriorly in the spinal canal, intradural extraaxial mass.
Okay, so on this slice here, this horizontal slice, this white oval is the tumor. What's this gray oval?
That spinal cord pushes back,
Okay,
push posteriorly.
okay. So the key thing on this slice here is the spinal cord should be in the center here.
Mhm.
It should be in the center and not under any pressure. And you can see that this meningioma in the spine is pushed the spinal cord back. Neelan, is this causing the memory issues?
No, it's not causing the memory issues.
Okay, so basically the patient wouldn't, if it wasn't for the memory issues, would never have gotten scanned, right? So
Yeah.
it's not really a symptomatic meningioma, but what are you concerned about when you see these pictures?
There's pressure on the cord there, and I mean, I think if it's not symptomatic now, and there's a significant amount of displacement of the cord, which indicates there's quite a bit of pressure there. If it's not symptomatic now, I think it will become symptomatic, and so that's the concern is symptomatic cord compression.
How long do you think this has been there?
See, probably are between 5 to 10 years.
Okay, so it's been growing over 5 to 10 years. Currently, it looks like to me it's occupying, more than half of the spinal canal.
Yeah.
Here, maybe half, maybe a little bit more than half. How long, if the patient did nothing, and the tumor continued to grow, what type of time frame do you think before the patient would start to develop symptoms?
I think probably in the next maybe 5 years, 3 to 5 years, I think they would start
Okay.
developing symptoms.
And that's presumably because the meningioma gets larger and larger, and at some point the spinal cord gets compressed more.
Yes.
Okay. David, so given what Neelan said, the patient's in her early 70s, not symptomatic from this, but Neelan's worried that it's going to be symptomatic in the next, few years. What are the treatment options here, or what are all the options on the table?
So by the way, I just wanted to add on like that, although it may grow slowly, like, even with mild trauma, she may have like really big spinal cord injury. So I would, as a prevention, I would rather recommend some treatment options. So the options includes surgery basically, and could also include radiosurgery and radiosurgery in combination as well. Or also like, we don't really have to rush into operate. So observation, like in a short term, could be also an option. Based on the imaging and patient's age, and patient doesn't have really like no neurological symptom related to this lesion, I would recommend surgery, because like when we consider radiosurgery, I think the dose going to the spinal cord will be quite high. So at least like we don't really have to reach to like the complete resection level, but still like having some decompression and having some space between the tumor and the spinal cord will have the radiosurgery option more feasible at this point. So that will be my recommendation. But I think waiting and fractionated radiosurgery is also not really a crazy idea at this point. Yeah.
Okay. Neelan, what are your thoughts here? Like what would you recommend to this patient?
Yeah, I agree with David, and I think in an approach to, because there's pressure on the cord, an approach of of open surgery for debulking, and then depending on the pathology and how much is able to be resected, then we can consider other options of radiosurgery afterwards.
Okay, but you don't think I think she's 71. At 71, you don't think she could live out the rest of her life by doing nothing?
I mean, in theory, she could. It's a bit of a risk, and then obviously you've got to weigh the options of her comorbidities. I mean, if she's sick, if she has, other things play into your decision about surgery or not. But I mean, to me, you can kind of gamble that she is gonna maybe live out her life without feeling any symptoms, but it's a gamble. It's a gamble either way. But I think with the surgery, you know what you can achieve, and I think going for surgery in this case is a good option.
Okay. This is another kind of view of the tumor here and the spinal cord here. This circle is the spinal canal. So in a normal person, the spinal cord sits in the center of the circle. It's got lots of space. Here you can see it's, I mean, if anything, the tumor is taking up like 70% of the spinal canal there. So it is occupying the majority of the spinal canal there. Okay, last case, and then we'll go to questions. So 54-year-old woman comes in because she got in a car accident, a fender bender, and you know, they were worried about whether she had any kind of trauma to the head. So she got initially a CT scan, a CAT scan in the ER. Something was seen. Now she got an MRI scan. She comes to your clinic. She's got completely no symptoms and a total normal neurologic exam. Never would be here if it wasn't for the car accident. Neelan, what do you see here?
So it looks like she's got a extra axial. So this is an axial cut with contrast, and she's got and it's giving us a view of the cerebellum, and she's got a extra axial a tumor on the left, just abutting the left cerebellum. We call this a CP angle tumor, and it's likely a CP angle meningioma.
Okay. And how long do you think this has been there? And are most people with this size meningioma asymptomatic or not symptomatic?
Most people with it, I would say it's been there for about 5 years. Most people at this point would probably be asymptomatic. Now there's this can grow and can start exerting pressure on the cerebellum and cause symptoms, but at this point it doesn't seem to be exerting much pressure on the cerebellum.
Hey, David, comments?
Not really at this point. Yeah.
What would you
I think-
recommend to the patient?
So I think all options are quite feasible for this patient. Like, patient is asymptomatic, and compared to the first case, although the size seems quite similar, there are some more space between the cerebellum and the tumor. So I think still we can safely observe. And also the other options, like either surgery and radiosurgery, both are feasible for this size and dislocation of tumor. Like we don't really have to worry too much about like adjacent structures at this point here. And also like surgical option is also very feasible. It's quite frequently used a surgical corridor here. So
Okay, so you said you told patients okay to observe, it's okay to have surgery, it's okay to get surgery with radiation. So, but what would patient says, what would you do if this were you?
I mean, I would observe for now. This was like just incidental finding, and like 6 months follow up, and then if there's any growth between those scans, then I would consider surgery.
Okay.
Considering the age, yeah.
Neelan, what would you recommend?
I agree with David. I wouldn't recommend, because she's asymptomatic this moment, I wouldn't recommend any upfront intervention. I would probably get another scan in 3 to 6 months and see if there's any change or growth of the tumor.
Okay, so if you observe and you get another scan in 6 months, what would make you, more likely to recommend treatment than continued observation at that point?
If I saw some growth in the tumor, and then also if there was maybe possibly some pressure, some displacement of the cerebellum, also if the patient became symptomatic as well in that interval, I would recommend an intervention.
What symptoms could the patient get from a meningioma in this location?
So they could get, because it's in the cerebellum, if it starts putting pressure on the cerebellum, they could have problems walking and with balance. Also, if I don't expect it to grow enough where it's actually kind of compressing, so there's that structure in the middle there, the fourth ventricle. I don't expect it to grow much to that it'll start compressing the fourth ventricle. But one of the problems with that is it could, with the bigger lesions, there's enough pressure where it kind of closes off the fourth ventricle a little bit, can cause headaches. So that would be another possible symptom.
Okay. Let's, I'm gonna open it up to now questions. It look like there's been at least 10 that have come in. So if you have questions, please submit them to the question and answer box, and we'll go ahead. And these questions could be related to the 5 cases that we saw, or the panel will be more than happy to answer any questions regarding, patient-specific meningiomas if you have a question about your particular case. So let me go to the questions. Okay. So the first question that came in, and I think it's because we were talking about the grades, so I'm going to give this to David because you were talking about the grades.
Yeah.
Would you consider a grade 2 meningioma a slow grower?
It's just relative. So like compared to grade 3, definitely it's a slow grower, but compared to grade 1, it's going to be faster. So we will expect faster growth pattern. Yeah.
Okay, so somewhere in between a 1 and a 3. So
Yeah.
grade 2 meningiomas, would that, if you knew something was a grade 2 and not a grade 1, would that change the frequency of your scans if you were following the patient's tumor?
Yeah, it may. Yeah. So, for example, for grade 1, I would just feel very safe to follow up in a year. But for grade 2, I would rather do like 6 months instead.
Okay. Next question, Neelan, do meningiomas cause pain?
No, not inherently. They don't cause pain. I mean, they can, if they're big enough and they have enough mass effect, they can cause headaches. Also, a lot of times if they're affecting a cranial nerve, like they're encasing a cranial nerve that that causes sensation. Like for example, if it's in Meckel's cave, and it's abutting putting pressure on the trigeminal nerve, it can cause facial pain. But not inherently, no. But they can, depending on their location.
Okay, so it's location specific then, right? Yep. Okay. So the next question, David, okay, the patient has a patient-specific question. They have a meningioma at the jugular foramen, extending into the IAC or CP angle, involves cranial nerves 6 through 11. The tumor measures 20 by 18 by 15 millimeters on the left side. Okay. Patient with the tumor is found incidentally in 2021 after patient fell and hit her head. So similar to kind of the auto accident one, they didn't know they had it. However, looking back at MRI scans in 2012, there was of a neck, they saw the tumor was there, just maybe smaller. Okay. But it kind of wasn't read on the 2012 scan because they didn't kind of appreciate it. It's only in hindsight. And the tumor looks like it's doubled in size from 2012 to 2021. Okay, so you got a 2 centimeter left CP angle tumor involving cranial nerves 6 to 11. Sounds like no cranial nerve symptoms, despite the fact that it's involving the region of those nerves. So the patient has received contradictory recommendations after many consults. One neurosurgeon recommended surgery, and then referred to their co-surgeon, a neurotologist, an ENT surgeon, who then felt that the patient should have radiosurgery or just observe. So comments on this. So 2 centimeter left CP angle, tumor asymptomatic, incidental finding. What are your thoughts?
Yeah, first of all, like I wasn't sure, like because it's 2 centimeter and involving from 6 to 11, that seems larger than 2 centimeter. But basically, based on that, I think both option, and I don't know the age of this patient, but I think radiosurgery itself could be a good option, and just so you can just watch and wait until it seems like growing a bit, and we can consider radiosurgery. But still, a surgical option could be feasible. I would like to see the scan, but yeah, based on the explanation, I think still surgery can be feasible, because although they reported as involving these cranial nerves, but it it may be better to see the image, basically.
Yeah.
Okay, so kind of basically sounds like very personalized, patient specific, depending on age of the patient, kind of shape of the tumor and whatnot. But assuming the patient, let's say, is middle-aged and got another 2 or 3 decades to live, would you be concerned about a 2-centimeter left CP angle mass at this point?
Yeah, I would do something at least, like, so I think surgery, although it may not be complete resection, but like surgical debulking, like, subtotal resection could be a good option, and then we can have pathology and we can consider radiosurgery afterwards. So
Okay.
that could be a good option. Yeah.
Okay, next question. Patients known about a meningioma for 12 years. It's just under 3 centimeters now, but they've known about it for 12 years, slowly growing. So it sounds like it's getting bigger on scans. Sounds like the patient's been told it could be treated with surgery, or you can continue to watch. Not too concerned about pathology because it seems to be growing slowly, so probably a grade 1. Location is along the anterior falx, mild mass effect on the adjacent frontal lobes bilaterally. So it's kind of like a falx meningioma that extends on both sides of the falx, 3 centimeters.
Okay.
No symptoms. What would you recommend, Neelan?
In this case, because I don't know how old the patient is. Does it say? No, it doesn't say. Okay. I think I would. In this case, it's in the frontal lobe that makes the risk of surgery lower. I would go for, without seeing the imaging, I think I would go for surgery in this case.
Okay, and
Open
why?
surgery.
Just because of the size?
The size, there's mass effect. Also, it's in the frontal lobe, which kind of reduces the risk of, it has a lower risk. There's less eloquent structures in the frontal lobe. Those things are figuring into my decision.
Okay. So no symptoms so far at 12 years. Are there any symptoms that could happen suddenly?
So if it, in the frontal lobe, there could be, if it starts growing, it's been there for 12 years, 3 centimeters, it's a sizable, she could start having personality changes, memory issues.
Okay, anything that could happen like suddenly, acutely?
You could also, if it's falcine, then you could also get kind of occlusion of the, I don't know if it's I'd have to see the image. If it's invading the sinus, you could get occlusion of the sinus.
Okay.
Yeah.
So also what is alluding to is the patient, even though they're not symptomatic now, a seizure is also possible. That could be a sudden onset of event here. So 3 centimeters is getting up there in size. It's kind of getting on the upper limit of the radiosurgery. So certainly if it gets much beyond 3 centimeters, you won't have the radiosurgery option. But it at 3 centimeters, that's the size of small lemon or egg, and we have seen tumors this size that are asymptomatic for long periods of time and then suddenly cause problems like seizures. So that's also a risk. Okay, the next question, I think this is getting back to that left CP angle meningioma, David, that you talked about, because some of these people have the same names. A couple of people are all anonymous and list as anonymous question. Okay, so sounds like hearing on the left CP angle mass 2 centimeters is diminished on the left side. Minor gait disturbances, some swallowing issues. Neurosurgeon's consensus is that the neurosurgeon who says do surgery says you're kicking the can down the road while you keep waiting. The neurologist says, well, if we go in there with surgery, it would cause a lot more nerve injury than you have now. So sounded like also there's a stem cell transplant for AML in the patient from 23 years ago. So first question, is the tumor a result of the total body radiation due to stem cell transplantation? So can you get meningiomas from radiation?
No, I mean, as far as we know at this point, there are no relevance proven so far. So,
Okay.
but
The second question, if radiosurgery was done first, would that affect the consistency or softness or whatever of the tumor if you needed surgery later? So if you had radiation first and then subsequently you had to have surgery, does a radiation cause any change in the tumor?
I mean, it may have, but like, for example, like I personally, I haven't seen like a meningioma case after radiosurgery, like being operated, realistically, but for like malignant tumors, there are differences after like SRS radiosurgery. So, but it doesn't really make surgery any more difficult or anything so much different than usual. So it wouldn't be like that. Yeah.
Okay. Neelan, a couple of questions I've asked, or how long do you think the tumor's been there? So one of the participants asked the question, how do you decide or estimate how long your tumor's been there when you only have one MRI?
I mean, we know we have some idea about, about the growth patterns of meningiomas from the literature, and just given the size on the initial imaging, we could we can likely tell how long the tumor has been there. But again, also what's also important is, if like we presented a couple cases where there was an asymptomatic presentation, I think it's important to get a follow-up imaging to get an idea of the growth pattern.
Okay, and then a follow-up question. How do you calculate the volume of a tumor? MRI scans usually give dimensions, right? 2 centimeters by 1.5 centimeters by 1.5. How does that translate into a volume?
So we just measure by multiplying XYZ axis and then dividing into 2. That's the usual way. But also, like we can use other software, like for example, the X-ray software that we use for radiosurgery. We can measure like really accurately using all slices. We contour each slice and we make this 3-dimensional measurement of the volume. Yeah.
Okay, so yeah, essentially what David said, multiplying the 3 numbers together and dividing by 2, that's kind of the rough estimate for a sphere. And so we approximate most tumors to be kind of roughly spherical. Obviously, the more irregularly shaped the tumor is, the more likely that estimate is going to be off. Once you have computers loaded into like a treatment software planning system like we use for radiosurgery, it'll calculate the exact, cubic centimeter volume based on computer software. So next question. 1/3 of meningiomas have estrogen receptors and 75% have progesterone receptors. What in general supplements, which kind of progesterone precursor supplements should be avoided? And they've listed a couple: DHEA, pregnenolone, and nicotinamide. Any comments, guys, on supplements that are precursors for estrogen type and progesterone?
Honestly,
I don't think there's good evidence either way to show that these cause growth of these tumors.
Yeah, so the question is, should any of these be avoided? So this is always a tough situation because while tumors have estrogen and estrogen and progesterone receptors on them, it's again, as Neelan said, it's not kind of clear that having more estrogen changes the growth of these. And on the flip side, people have tried kind of anti-estrogen and anti-progesterone drugs on meningiomas to slow growth, and that doesn't seem to stop them from growing either. I do know that some people, some physicians, just because they want to be safe, will say, well, try to minimize any kind of hormone replacement therapies, if you got a meningioma. So if you're on birth control pills and whatnot, try to stay away from those, or hormone supplements. But there's not a lot of clear evidence for that. Okay. Next question. How much growth do you need to see to recommend removal of the tumor? So let me maybe give it a little couch that in a little bit more detail. Let's say you get an MRI scan, and let's say 6 or 12 months later, you get another MRI scan. At what amount of millimeter growth would you be concerned about? Like if it's grown only 1 millimeter in a year, is that a concern? And if not, when would you be concerned?
I think this will be not only by like quantitatively, but also like, so if I can see growth change like grossly, like just by seeing the images, if it looks obvious, then that's certainly a concern. If it's less than 1 millimeter, then I would say it could be just a measurement error, because the angle of the MRIs could be different, and the measurement could be always different. So that will not be a concern. But for example, if like there's a sphenoid meningioma and now like it's touching the optic nerve, that would be a bigger concern. So I think the location also matters a lot. Not only the exact millimeter of growth, but I would say like more than 2 millimeter will be a concerning issue.
Okay. And I think the other question is, how big is it to start? Like if a tumor is pretty large, it may not take much growth to tip the patient over the edge clinically.
Yeah.
Okay, so next question. I think this has had to do with a kind of a, let's say you have a meningioma in the right frontal lobe. How long should you wait and how much kind of pressure on the brain is it safe to wait to have a meningioma? So you have a meningioma in the right frontal lobe, it's pushing on the brain. When do you worry about it? Like how much pressure is too much pressure? We saw that one case where I presented where we had that large meningioma was causing swelling in midline shift. That's obviously a lot of pressure. But when would you say you're getting nervous on pressure?
I would say
Yeah.
like, Neelan.
Go ahead, David.
So I think the main key will be the peritumoral edema, like swelling nearby the tumor. But even without that, when I see this question, I think there's no point to wait until that point. So like if the tumor is growing, even without surrounding edema, like it's better to resect or do something before it causes any issue. So the reason why we want to observe is that we want to see whether the tumor is growing or not. That's the main thing. We don't want to wait until it grew, the tumor reached to a certain point. So
yeah. So what David's trying to allude to is that generally when we do surgery or whatnot on a patient, the best predictor of how a patient does after the surgery is what kind of shape they are in before the surgery. So if the patient's in good shape because the tumor's either not symptomatic or minimally symptomatic, then resecting the tumor should be relatively low risk. And the expectation is the patient should come out of the surgery the same shape they were coming in. So if they were perfect neurologically, we expect them to come out perfect neurologically. If you wait till the tumor is pressing on the brain and the patient's starting having some symptoms, you're now starting at less than a perfect level. Now, instead of 100%, now you're 80%. And not only do you have to remove the tumor, but then you have to hope that the patient can recover that 20% of function that was impacted. So, Doctor, I think David and Neelan are correct here, is that you can't just kind of, the MRI scans don't give you a pressure reading. You can look at some, secondary factors like how much swelling there is, or how much midline shift there is. But generally, because we've seen a lot of meningioma scans, we have a good idea kind of like where a patient starts getting into trouble. And so when we talk about, hey, you should start to consider surgery based on the size, we're not necessarily just only focusing on your scan. We're looking at the combined experience of all the scans that we've seen in meningioma patients, and to get a sense of like when we think a patient might get into trouble. Okay, next question. Would you consider a grade 2 meningioma aggressive? Neelan, do you want to?
Yeah, I would. So I think David kind of addressed this a little bit earlier, but yeah, I would consider it's intermediate aggressive, somewhere between grade 3 and grade 1. And I would definitely have more interval imaging, increased frequency of imaging if I'm observing this. So decreased time between scans basically for these patients.
So if you're following a grade 1 meningioma every year, or a grade 2, you might scan every 6 months.
Every
because-
6 months or possibly 3 months,
Okay.
depending on the growth pattern.
Okay, David, we talked a little bit about the hyperostosis. So a question from one of the participants is meningioma, we talked about meningiomas going into bone. Are there special considerations for radiation therapy, either radiosurgery or fractionated radiation therapy of bony invasion compared to soft tissue?
It's not really about like bony invasion or like bony tissue or soft tissue. So for example, the case that I saw, like, I think like third case, the one in the sphenoid wing, the bigger concern is whether it's closer to, like, very close to critical structures like optic nerve. So that makes, decision of like whether we do radiotherapy or radiosurgery, or whether we should do hyperfractionated radiosurgery. But like if it's, for example, if it's like in convexity on the back sub part of the the bone and skull bone having bony invasion there, it's not a, you don't really have to worry about like that, and we don't really have to like fractionate it based on the bony invasion there. Yeah.
Okay. Next question. Can immunotherapy drugs be used postoperatively to reduce recurrence for grade 1 meningiomas?
Not that I'm aware of, no.
Me too. Yeah, I think nothing proven at this point.
Okay. Next question. 58-year-old female, meningioma discovered 5 years ago at the T9, T10 level in the spine. Completely asymptomatic. Serial MRI scans are showing growth over time and impingement on the spinal cord. Is surgery a reasonable option at this point?
Yeah, just not from look. I haven't seen the scans, but I mean, from the description, I would say yes, definitely surgery is a reasonable option.
Because of
The growth and the compression on the spinal cord.
Yeah. So again, this is one of the things, best predictor of how you do after surgery is what kind of shape you are coming in. So if you're currently not having any neurologic symptoms, you're the best. You're at 100% function, and it's you. In this case, it sounds like you followed it for 5 years. It's growing. It's demonstrating that it's doing what a tumor normally does, which is to grow. And in the spinal canal, like that one case that we showed in the spine, in the cervical spine neck, they can take up more and more of the spinal canal. And at some point, you can get into trouble. And then at that point, you may be starting from a neurologic deficit. And not only do you have to have surgery, the surgery has to be done on a more urgent basis because now you're symptomatic. And now you got a deficit for which you have to recover from. So at 58, there's a good chance, I mean, that's still very young. Good chance that you're not going to be able to just live out your life without having this addressed. And so addressing it sooner before you're symptomatic makes a lot of sense. Next question. If a meningioma is shrinking after stereotactic radiation, how often should a patient have MRI follow-ups?
I think the shrinkage doesn't really change the plan for follow-ups. So I mean, if it's stable, then basically we'll do like 6 months in the beginning. But so the higher chance of, a recurrence is like right after, I mean, it's going to be closer to the treatment date. So after 6 months for several years, then you can stretch out to year, 2 years, 3 years, something like that. So, but shrinkage will not change any further plan for follow-ups.
Right. Okay. So essentially the more scans you get that look stable, the more you can kind of relax the frequency of the scans. So as David alluded to, whether you do radiosurgery or surgery, the first couple of scans may be, every 6 months, and then you scan once a year for a couple of cycles, then every 2 years, every 5 years, et cetera. So the further out you get, the less frequently you need to scan. Next question, 7-centimeter chordoid grade 2 meningioma in the right temporal lobe, growing between skull and the membrane, pushing midline shift of about 14 millimeters. It sounds like 100% removed along with cybernet from the residual. What's the chance of regrowth? 49-year-old grade 2 chordoid meningioma. It looks like it's a gross total resection followed by radiosurgery.
Mm-hmm. I think it's hard to give the percentage, but very, very low, I would say, like, especially if it's like really 100% gross total resection, then that means like basically there's no residual. So it should be like maybe less than 1% then.
Okay. Next question. I'll probably just answer this one. So with a meningioma, do people normally only go to the neurology clinic with the residents? You know, most academic medical centers are high volume centers for meningiomas, and a couple of kind of just general comments. Generally, you want to be seen for your meningioma at a high volume center, a center that treats many meningiomas each year, a center that offers all the options available, surgery and radiation. And as Neelan alluded to in the beginning, sometimes you have to combine the treatments. And the reason why a high volume center is important is that those are the people that have a lot of experience and expertise with managing meningiomas. You know, it takes a certain number of these you have to do each year to maintain your skill set. And then also in a high volume center, if there are any issues or symptoms that come up, it's a much more likely scenario that a high volume center would have seen other patients in the same situation and have a lot of experience in managing them. You know, I do typically recommend that patients with meningiomas be seen at a high volume academic medical center, just because of the broadness and the depth of experience there. The next question, I think this is the last question that I see. What are the disadvantages of doing radiosurgery? Craniotomy seems invasive when the tumor is not located in an area that is high risk. The recovery is easier. I'm not concerned about any tissue analysis. So what are drawbacks to radiosurgery in general?
I would say
Go ahead.
Yeah,
go ahead.
Go ahead.
No, so with the radiosurgery, it is less invasive, but you don't necessarily decrease the volume of the tumor. There are chances that the tumor will shrink over time, but it's likely going to stay about the same size. And if you have pressure or mass effect and it's causing symptoms, those aren't going to go away necessarily with the radiosurgery.
Yeah, I think that's a great point. So, you know, radiosurgery particularly for benign tumors, I call it freezes the tumor in time at that current size. So now you have a dead tumor the same size as your live tumor. If there is any pressure that tumor is putting on the surrounding structure, that pressure doesn't necessarily change because you still have the same size mass pushing on it. And while you may not be symptomatic now, you might be symptomatic in the future from that pressure. You know, 6 years of pressure is more likely to cause symptoms than 6 months of pressure. So as you get further out, that's an issue. The other disadvantage of radiosurgery is you're making a lot of assumptions. You said you're not concerned about the tissue analysis. A couple, you know, if you've been following the meningioma for a while and it hasn't changed very dramatically, that indicates it's probably a grade 1. But you know, if you've gotten just a first MRI scan, you see a meningioma, you don't know really how long it's been there. The higher grade meningiomas, like a grade 2 and particularly a grade 3, have much higher failure rates with radiosurgery. So if you have a meningioma and you do radiosurgery and it grows pretty quickly over the next 6 months, you're probably not dealing with a grade 1 meningioma. And now you have a larger tumor to address. So you, by not having the tissue pathology, you've kind of hurt yourself by doing a treatment that had a lower success rate. So that's another issue there. Other than that, you know, radiosurgery typically has, you know, it has advantage of being outpatient and non-invasive. You just need to understand kind of what the relative trade-off is in this situation. Okay, I think that's the questions that I've seen in this system. Any other last questions from the participants? If not, I want to thank David and Neelan for their generous contribution of time on a Wednesday evening. We hope this was helpful. presentation has been recorded and we'll have it up on the web and for anybody that wants to review it. Thank you again for everybody's time and attention. Take care. Have a great evening.
Thank you. Thank you, Dr. Chang.
Thank you all.